everybody. So my name is Dr. Pham. I'm one of the chronic pain physicians, and we're located in Louisville, about 25 minutes away, okay? So, a little bit about myself. I'm from New Orleans originally. It's Mardi Gras this weekend. That's where I'm headed, you know? So this is the time you'll see me not inebriated for a little bit. So basically, I went to LSU for medical school, Tulane for undergrad. I went to the West Coast to UCLA, saw great things. It was like one of the best pain programs. The best thing is that a lot of the new pain stuff comes out from there. So I wanted to return home, at least to the South, and try to manage people's pain without heavy opioid use or a bunch of steroid exposure. Because as you guys know, they're bad for you. So that's a little bit of New Orleans. I'm probably going to see all 4 of these tomorrow. So, all right, cool. So just a little bit about our practice. It's me and one other person who's also from New Orleans. We care a lot about our patients. We try to get to know everybody, to a point where sometimes they have to drag me out of the room because they talk so much. But we from New Orleans and from him, we're a family over there. Okay, so we focus a lot on everything: physical therapy, chiropractor, massage therapy, all this stuff that's very safe for all of you guys, because we want to just get y'all back on your feet. And, if that doesn't work, we move on to, more advanced stuff, okay? So, if any of these stop you from living your best life, then we're the person for you, okay? So we do everything, from head to toe. We do headaches, neck pain, upper back pain, middle back pain, lower back pain, sciatica. We do shoulders. We do hips. We do knees. Oh yeah, go ahead.
Do you do pain in the ass?
We do pain in the ass. But usually,
No, that's called retirement.
there's a treatment for that, I'm sure. My fiance said the same thing to me. I still haven't found a cure yet. But I like you. I want to see you. Yeah. So basically, all of these things. My father was a veteran. He's a Vietnam War vet. He deserves everything in the world. Before he passed, he always had these aches and pains. And my only regret is that I hadn't known about all this stuff while he was still living retirement. But he loved fishing, but he was always limping because his knee hurt or his lower back hurt. He had bone spurs everywhere, and I was like, the pain doc he had wasn't worth a damn. At least the way I saw it, I was like, do something, But he kept giving him hydrocodone instead. And that wasn't cool, So I wanted to do something different and bring it back to the South, So that's what we're about to get into, okay? So, what we see a lot, okay, with anyone above 45, all right, is we see a lot of lower back pain from degenerated discs, arthritis, okay, pain in the hips, SI joint pain, okay? Every time you sit and you're hurting, that could be your SI joint, that could be your arthritis in your lower back. Every time you lean forward and that hurts, that could be your discs. Every time you twist and turn, that could be your disc and your degenerated joints and things like that, okay? So every time y'all sit down or you're leaning or it hurts, all right, that's something that we can help you with and fix, okay? Every time you limp, every time you swing a golf course or a tennis ball, or you're struggling to get out of bed because you're stiff or everything hurts, we can help you with that, okay? So this is how we're going to help you, all right? So we do a lot of the basic stuff first, okay? We can burn nerves. We can do steroid injections like everybody else, okay? We can burn, arthritic nerves in the knee, nerves in the shoulder, nerves in the lower back and in the neck, and get you out of pain for about 7 months to a year at a time, okay, safely. And then we just redo it, okay? That's our conservative end. Okay. Oh yes.
What do you mean burn and nerve?
Okay, sounds more dramatic than it is, but some people think, I gotta rephrase that, okay? So, you want me to rephrase that? Okay, so a lot of people think that we take a hot poker and we just stab the nerve. Not true, not true.
You don't feel the other pain.
Yeah. So, the way I explain it is that if there is pain, there is a nerve that's transmitting that pain, okay? Everywhere in your body, and that's where we come in, okay? So, what we do is we take a small needle, we heat it up to a certain temperature. You can be asleep. It's very comfortable. I use a lot of numbing medication, okay? The vast majority of patients love it, they tolerate it, and they love the results, okay? The nerve goes to sleep, okay? The nerves go to sleep. They go to sleep for 6, 7 months, a year, okay? And during that time, patients are walking better, they're playing sports, they're hanging out with their grandchildren, they take less hydrocodone, ibuprofen, Tylenol. Like, I've seen it myself. You know, I've seen that their gait is better. They're not limping anymore because the pain isn't there anymore. Okay, and so go ahead.
So after you cauterize it, does it rejuvenate?
It does
organically?
rejuvenate. Yeah.
Do the synapses go back and reattach? How does
Yes.
that play out?
Exactly. So, good question. 6 or 7 months on average is when these nerves tend to grow back, and that is when insurances cover to reburn it again. Okay. The reason why is because the sheath that is covered by the nerve that allows electricity to go through, it also acts as a healing factor for the nerve to return. That's not all nerves, okay? That's not all nerves, but unfortunately, these ones that are easy to burn are also easy to grow back, okay?
So
But
after a pattern of that, does it just become more?
more deadening, yes. So eventually what happens is we can space it out. These 6 months, 7 months, a year, things like that. That's what I've seen personally.
It just atrophies over time?
It just atrophies over time, but it doesn't go away forever though.
Right.
Eventually, some people
That's right.
need it 1 year or 2 years, okay? But these are, now this is why it's attractive to a lot of people, okay? It doesn't require surgery. There's no incision. It's just 3 little pokes that you can barely see through your skin. Procedure's only about 10 minutes. You're in and out, boom, out of pain relief for about 6, 7 months or to a year at a time, for 10 minutes of your time. Yeah.
Where will the need be going?
So, if I were a patient,
Okay.
I turn around, it would be right here in this little back area.
Okay.
Now, it doesn't go into the spinal cord. I want to be very clear, okay? We don't do that because I'm not a terrible human being. Okay, so it only goes to the nerve that is transmitted from the arthritis. Okay. Now, this same concept, imagine the nerve that's causing arthritis. You have the same nerve here for superior cranial that's 20% of lower back pain. You got the same nerves that are in the neck. Okay. So every time, if you find yourself, okay, you'll know you'll have neck arthritis if you're turning like this. You're turning your shoulders like Batman. Has anyone ever seen like Michael Keaton's Batman? Okay, no, I guess. But if you can't do this and it's a problem, that means that the joints are arthritic. It's bone on bone. So the same nerve that causes that pain, we can get rid of it. At least
Do you use an ultrasound or you just eyeball it?
X-ray.
Ah,
X-ray.
Ah.
We always know where we're going
For
before
sure.
we go.
Yeah.
Always. Don't ever let anyone tell you otherwise. Okay. Yeah.
You think?
Like there are some people who are like, okay. I'm like, go to somebody.
Yeah, right.
Yeah.
That's where you lick your lips and yes.
Yeah, so when I see older patients, and our patients are nice, I love them, remind me of my parents. I just want them to live their retirement because they deserve it. Spend money to the IRS only so you can't enjoy the rest of your life. So
How deep does that go in?
the needles in the
Yeah.
spine, probably about this much.
Okay.
Yeah. So that is actually our basic procedure. That's the most common thing that we do, okay? But this is what makes us special. I'm about to move on to more special stuff, okay? So for a lot of your friends or yourselves who have arthritis in the knee is usually the first joint to go, okay? Every time you walk, every pound that's on your body is 5 pounds on your knees. That's the statistic. So when you lose weight, 1 pound off, that's 5 pounds off your knees, okay? But the knee is the first one to go. So if you see this picture up here, this is an x-ray of a patient who already has a knee replacement, okay? But 20% of them usually still have pain, okay? Now what happens is right here and right here on the side, those are called genicular nerves, and they're responsible for the majority of your knee pain, okay? So this patient came to us and he was like, I'm on my 2nd or 3rd surgery, I'm so tired of it, I have scar tissue, nothing works. And I was like, well, it's not a knee problem, it's a nerve problem. So we simply put these 2 wires underneath the skin along there, and as long as those wires are there, they turn off the nerves, okay? Because nerves are circuits. All you have to do is just disrupt their function, no more pain, gone.
So how's it rejuvenated? How's it generator?
So,
The wire.
the wire, okay,
The
so
source.
the wire is coming to, actually, I'll just skip ahead, okay? So, this is the generator here, okay? So, it will supply a current, okay, that matches the nerve signal,
Mm.
and it will turn off these nerves, okay? 1, 2. You
So
hands
it's
go.
external?
This is underneath the skin,
Um,
but this little pocket, this little battery is above the skin, okay? So it's about this size. You just wear a little plastic thing, you wear it over it, and as long as that is there, it powers this generator. And the generator is this small, okay? It's very, very small. It will turn off these nerves. And on top of that, let's say you left it on overnight, you turn it off, you're actually getting pain relief for about 1 or 2 days. The nerve is still asleep, okay? So you don't actually always have to wear this. I prefer patients to wear it all the time because you'll always have pain relief, but you can put this in your knee, you can put this in your shoulder, you can put this in your lower back, in your neck, the superior flumeals, you can put it for feet pain, you know, and these things are amazing. Like, this has been a really big game changer for our patients, okay?
What's the
Because-
reference? How do you reference that? You call it?
Oh, a peripheral nerve stimulator, officially. Yeah. So this is what we did a lot at UCLA, okay? And I was skeptical myself. I was like, this seems like I can't cuss on this video. This seems like a lot of jargon BS, you know? But then I saw it myself. I put it in myself. I saw these patients come back, and they're not limping anymore. They're like, this thing is like a lifesaver for me, you know? And here's the thing. If a patient still wanted a knee replacement, even after, for some reason, they can still have it. Surgery will always be on the table. You know, it doesn't stop you if you don't, you know, physically. But most patients, once they have this, then they don't want surgery, unless your knee is unstable. So if a patient walks in like this, I say, you know what? I can get rid of your pain, but you're still going to fall. I'm going to send you to surgery. Okay? I'll do what's best for you. You know, I don't like surgery, but if you need it, you're going to get it. Okay? But for the most part, it's usually pain that stops people. Okay?
This works with bone on bone?
Yeah, even bone on bone. In fact, the reason why we see a lot of bone on bone is because patients, their BMIs are so large that they're not surgical candidates anymore. Okay? You have to have a certain weight to do surgery safely. I'm an anesthesiologist by trade. I would say no to your surgery if you are, you know, you are at risk of dying from anesthesia and from the surgery itself. Because when you're really large, okay, I call it the New Orleans special, actually. You'll bleed a lot more. You'll clot faster. By the time they get down to this knee, you've already lost about 2 or 3 liters of blood. You know, and I've done it. I've transfused many patients for life. So surgeons send them to me. They're like, listen, this patient has end-stage knee. I can't do any surgery. Can you help? I'm like, yeah. We can at least get rid of their pain while they lose weight. And sometimes that's all they need is just this, you know.
How does that supersede addressing valgus?
Valgus?
Bone on bone.
Yeah, so structurally it will not change.
Correct.
Anthony.
That's right.
Yeah, structurally, that's why, if
I
your
know.
knee is unstable so
Right.
bad, I'm sending you to a knee replacement.
Right.
But if you're not a surgical candidate and you have pain, then yes. If you have valgus and you have pain from it, I can get rid of that pain for you.
But the valgus remains.
The valgus remains.
Of course.
Yeah. So, I'm not gonna lie to you and tell you that even.
I appreciate you stating facts.
Yeah, and I'm not gonna do a knee replacement. Don't let anyone tell you otherwise either. It's good, okay.
Yeah, so you use that device too on the spine like at L5S1?
Yep, exactly. So
Okay.
you can actually do it, let's see, where's my other one? Okay, here's the spine. Let's do this one. So L5, S1, L4, L5, okay? So this is where you wear your belt, okay? Right here.
Right.
This is where most of your lower back pain, L4, L5, L5, S1, okay? This is the problem child for the majority of America. So what we do, okay, do you remember those little nerves I was talking about that we can quote unquote burn, right? Well, let's say that the burning, like you said, it lasts 6 months. Most patients will will last just about 6 months to a year. But let's say that it lasted 6 months, and then it lasted 3 months, and it lasted 2 months, for whatever reason. Maybe it got worse, you know, but you're not a surgical candidate, or you don't want surgery, right? Those very same nerves, we put those 2 wires along it. That's it, same thing, you know. I've done it for about 5 patients already, okay? Pain is relieved. She was too old for surgery. She was like, I'm good. I'm good. Now, here's the best thing about it, okay? None of this stuff, I didn't mean to talk about the PNS, the whole, rest of it, but it's amazing, is there comes a trial period first, before you permanently implant anything. So what do I mean by that? I mean that you come to our office, we put a wire in, we send you home for 5 days, okay? During those 5 days, you ask yourself, are you able to walk better, sleep better, do all your activities better, okay? Take less pain medication. Finally sit down without thinking about, man, my back is hurting, maybe I should reposition myself or something, you know? You come back 5 days later, we pull this wire out of the office. That's it, 1, 2. The answer is yes or no, and usually the answer is yes. And then if the answer is yes, then we talk about permanently implanting.
How do you address the water issue? Is it just watertight? Of course, there's an opening in the epidermis, so.
Oh, yes, so it has to do with anatomy. So let's go for the trial first. When we do the trial, the wire goes through the skin and then it comes out into an external battery. That's the trial phase, okay? So our question is, what happens to the interface between the wire and the skin? Is there infection get in there? Does water get in there? Well, it's actually pretty tight. So when we put the wire in there, okay, we put the wire in there, and then the skin closes over it like this. 1, 2, 3, 4, 5. Micro, okay? That's 1. Number 2, we put antibiotic ointment. 2. Number 3 is I just put a tight bandage on it. That's usually does the trick. Yeah. So it's really tight. You won't get any water in it. There's no bacteria that gets in it. If you want antibiotics, we can do that, but generally I've never prescribed a single one because I've never seen an infection with it.
And it just heals.
Just does. Yeah, that's why we love it. There's no incision for the trial. For the implant, the incision will probably be about this small. No wider than the tip of my finger. Okay.
Do insurance companies approve this?
Generally, yes. There are some that don't, but that's another question. But most of them do.
Is Medicare happy?
Oh yeah, they're happy. Yeah, they're actually the easiest to be honest
No,
with you.
they
Yeah.
usually are.
Yeah. And they do prior auths. I'd be happy to die on this hill and tell them that this works. But this has been out for about a decade, to be honest with you. So they have plenty of time. And they only pay for stuff that has research back and that works. So.
I'm currently doing decompressions also, and will that interfere with the?
You say like you're stretching, decompression, like chiropractor was decompressing it?
Yeah, where you get on the table.
No. That should be fine. That's
Okay.
fine. Yeah. So the only I'd say downside in a way is that if you need to get an MRI, you have to it's still MRI compatible. Don't get me wrong. You
But
just
you
have to
use that, yeah.
you have to use the
Or
little
then
bar.
scatter,
Yeah. Now that goes for any implant in general.
For sure.
To get a spinal cord stimulator, they give you a card. You're like, hey, it gets in the weeds and details, T2, T4, but either way, it's still MRI compatible. You just got to go to some places out here.
Can you get on an airplane?
Yeah, absolutely. 100%. This is not to limit your life. None of this stuff is to limit your life. It's to facilitate it. So, all right. So that's just one of the things that we talked about. Okay. The other thing, okay, is we do have a spinal cord stimulator. Have y'all ever heard about that before? Okay. So this is basically patients who have persistent lower back pain and sciatica that goes down the legs. Okay. We do it a lot for patients who have had surgery and still have a lot of back pain and pain going down the legs, can't live their lives, so we put one of these in there. It's the same concept, except this time it does lay on the spinal cord. It's safe, it works very well, and I'm going to show you a bunch of pictures of people who are happy with it. Okay, so.
So as you feel better, now the Dixie has worked, so of course, movement is medicine.
Yep.
So now you feel better,
Yeah.
you're further damaging, because you don't feel pain.
You will, so that's a good question. You will Yeah, yeah, yeah.
Repeat your question.
So you will not, this is true across the board, okay? This will treat your chronic pain,
Mhm.
okay? And it will facilitate physical therapy and movement, as you know, movement
Right.
medicine. But if something horrible happens, you're gonna feel it. Like, let's say, for example, like, and I've never seen it, but let's say like, you have one of these in it, for example.
Right,
Helps with your chronic pain.
correct.
But if you have a disc herniation, all of a sudden,
Right.
you're gonna feel that. You are gonna feel that. You're gonna feel that.
So
If
does
somebody
it
stabs you,
supersede the actual healing process because you're more active, because you're not in pain?
does it supersede, wait,
The
say that.
healing process.
Mhm. Oh,
Yes.
does it
Because
facilitate?
you're right, because you're not in pain,
Yes.
so you're increasing the damage.
Not necessarily, and here's why. So, remember it comes back to motion is lotion, okay? And I'll explain this. The reason why your joints and the discs in your back, okay, these right here, all right, they don't have blood vessels. They just don't. They don't,
They
yeah,
don't
so-
impact.
so this
Yeah.
is how your body feels, and I just took my pain board, so I'll just tell you, okay? When you guys are sleeping, all right, your body doesn't heal with blood vessels as much in these and in your knee joints and your shoulder joint, okay? They heal by diffusion. So what does that mean? That means when you're sleeping, you don't move, and you're laying flat, that is when osmosis, all the nutrients and healing factors comes in, okay? All right, and then also, the opposite end is when you're moving.
Right.
Okay. So, for example,
I forgot about that.
Elbow, if I had arthritis in here, I'm actually healing it by moving it.
Mhm.
Don't think, when somebody says motion is lotion, I used to think that was a bunch of BS, but it's actually true, because there's no blood vessel. My heart's not gonna pump healing factors into it. You gotta do that yourself. You gotta move around.
Yes.
Yeah.
You do for yourself.
I do, because this stuff works, and I wanna make sure that everyone is taken care of. Okay? Actually, I just love this stuff. But the truth is that I never do stuff that doesn't work. If it feels wrong or it's not working, I don't do it. I don't care if anybody tries to pay me a bunch of money. I don't care if my boss is like, fire me. It just doesn't work, it doesn't work. That's it.
So you guys own or you're owned?
That's right. Exactly.
Are you own or are you owned?
Oh, I'm young.
I
But-
know, sir.
Well, I'm a W-2. Yeah. They asked, this is off topic, but they asked me to to buy into the practice and stuff, but, my fiance is from New Orleans, and we're, maybe in 2 years, if we have a kid, we might end up going, because my parents are getting old, or her parents are getting old, so. But,
Okay,
that's a side point.
got it.
So, yeah, that's one other thing. The other thing is like spinal stenosis, okay? So if you see yourself hunching over like this, you all seen the shopping carts on where you're going to the grocery store? You're doing this, okay? That's because after 50, we started seeing what we call spinal stenosis, which is this, right here. The spinal cord is in purple, so this giant ligament here is pushing into it. And every time it pushes into it, it causes pain in the back, and it shoots down to the thighs and the hips and the butt, okay? And the only way to relieve it is to lean forward like this, okay? So if you find your friends or yourself doing this, just think about it, okay? And when you go into a shopping cart and you see somebody leaning on it like this who's past 50, it's because they're trying to make sure this isn't worse, okay? That little green thing is pushing in, okay? So we have the ability in about 20 minutes just to shave this a little bit, thin it out, and boom, that pain is gone, okay? So everything we do is like literally about 20 or 30 minutes long at best. You leave the same day. There's no or barely any recovery time. You're not on rails trying to like struggle to get out of bed. You're not any of that stuff, okay? We don't do that stuff, and I don't want to do that stuff, because then it becomes surgery. We don't do surgery unless you really need it, and then we say so.
You do manipulations?
I don't do manipulations. I can say to a chiropractor.
Right.
I'm not sold on it yet, but chiropractors do help patients. I just don't like when they twist your neck. It makes me nervous. But I'm not saying that's against it. I'm just saying that it just makes me nervous. So, so this is just an example of the burning of the nerves, quote unquote. Okay, we just put a little needle right here, and then we just heat it up to a certain temperature, and those nerves go to sleep. Okay, so right here, I want to talk about. This is one of our pride and joys here. Okay, so what you're looking at here is you're looking at the knees. Okay, and what happens is we see then somebody says, okay, you need a knee replacement because you failed all those. The answer is no, unless it's end stage, okay? So we offer something, okay, two things that have helped a lot of patients, okay? One is the wire I was talking about. The number two is, if you don't want an implant, okay? If you don't want it, you don't have to have it. You see this black here? This black? This? Right here? So what happens is, when your knee is inflamed, okay, bone on bone, alright, the inflammation sprouts abnormal blood vessels. Abnormal. Okay? And why am I talking about this? Because the abnormal blood vessels feed into these nerves and the inflammation itself that is causing you pain, okay? So we have an interventional radiologist on our team, okay, who does this specifically. These little abnormal arteries right here, 1, 2, 3, 4. He puts a tiny little bead there, and it just chokes off the artery. It's only for pain, okay? It's only for pain. It chokes off a tiny, tiny little artery, not a big one. The artery you can barely see. These are the abnormal ones, okay?
Oh.
Yeah, just the abnormal, not any function.
Okay.
Okay, let's be very clear. Yeah, we don't do that. So these patients, it's a 30-minute procedure. They leave the same day. They're out of pain for 3 to 4 years at a time. 3 to 4 years. I'm not kidding you. I mean, we introduced this probably a couple months ago, and this has been the biggest game changer for us.
And
Because
circulation doesn't affect the heart.
nope, the beads don't go anywhere. They don't go to your brain. They don't go to your heart. They don't. Trust me. I have researched this left and right. I sent my own father-in-law last month, and that was only after I was like, I want to see some full proof.
Is
that
it an
this works.
acronym? Is that why it's mild?
No. This is a different procedure.
Oh,
Yeah. So this is technically called genicular artery embolization. They're embolizing it. Yeah. So this has been amazing. The oldest patient I've ever sent was like 95, 96, you know? And like, his walking is better. His walking is way better. Like, when I tell you, when I send my father-in-law, it's gotta work, and it works. He's golfing better. Okay? He's gonna go do the other knee at some point, but, you know. In fact, what he did was, because he's from New Orleans, he drove all over to our clinic in Dallas, he did the procedure that same day, and then he drove back the next day. He drove back. I told him not to, but he drove back anyway, and he was fine. He didn't die somewhere, you know. So that's how much I trust it, you know. So you can do this.
Because you've superseded it, and the body's happy now, and it's like a child that's whining, and it's having a party, and you're not invited. Okay, now it's kind of more compliant.
Yes.
So does the valgus slowly dissipate, or no? Not realistic.
Valgus has to do a lot with muscle mechanics too. So
Right.
when you're doing this,
But
it
you're
is.
compensating, which is why you're doing it.
Yeah, exactly. So what we do is I always ask my patients to like keep walking and keep doing physical therapy because to answer your question about valgus deformity, you know, in words is it's all comes from here actually. So if you're weak core and then you're standing like this and now you're compensating, boom, the inner knee is usually the one that goes out, the inside of it, right? So we facilitate physical therapy. So my father-in-law, he's working out now, not anything crazy. It's just that he can now do like more leg extensions, more core, without stopping and being like, okay. So by then he is healing his knee by more motion.
Right.
And number two is he is structurally healing himself.
And splinting using muscles.
Exactly.
And that
Yeah.
straightens, yeah.
So our core is God's greatest back brace that has ever given us, honestly. Like, if you keep everything tight, the core, your disc won't pop out, your arthritis, instead of you walking like this, you're walking like this on your knee, but with strong muscles, you're walking like this again. And that's the way a joint was designed.
In a perfect world, that
Yeah,
does
in a perfect world. But pain is an inconvenience. Pain will stop. Pain will make you weaker. Okay? It'll make you weaker.
Oh,
Right? So, you know, that's why we do this stuff. Okay? I will never tell you to stop me. I want you to move. I want you to walk.
oh, yeah.
I want you to strengthen your core. I want you to work out your glutes and your abs, the most inconvenient things in life. Do those two. I want you to work them out. Every time you sit, your abs go out, your glutes go out. And guess what? You start looking like this extremely, and then the arthritis kicks in. And then the discs, okay, the worst position you can ever be in is leaning forward and twisting. That's 300% of pressure on your disc, okay? I know this because I just took my board. I know this.
I know
Okay,
that too.
so please do not ever lean over like this and twist. If you can help.
Position.
I know. Kind of. So just, if you can just chest up, okay? Chest up. My father-in-law taught me the swing, okay? Elbows, that's fine, but please keep that in mind, okay? Because when that disc comes out, it's a beat to just get back in, okay? We can still help you with that, that's no problem. Bye. Okay. So the other thing is the SI joint. This is usually for our female counterparts, okay? SI joint dysfunction counts for about 20% of lower back pain in America. It can happen to men too, but when you wear the belt, if there's ever pain below the belt, near the butt crack, just think SI joint. Okay? It's usually a little looser in our female counterparts because of the birth canal, but also because estrogen, progesterone makes it more lax, and then weak pelvic muscles what makes it even more lax. So we can permanently fix that. Okay? We can just put a little graft in there. That's also a 20-minute procedure. It glues it together essentially. You know, you walk away the same thing. It's permanent. Your pain is gone.
Is it a mesh graft?
It's a graft.
A
Yeah.
graft?
It's an allograft.
Oh, you do an
Yeah.
allograft?
Yeah. We don't do any giant metal because if you do giant metal, it's a surgery,
Yeah.
and the recovery is going to be a lot longer. You know, but we do it for men too. Okay, men also have SI joint. So I'm trying to tell you guys like what to look out for because of what's happening in your body. You know, like you said, you never know when you're injuring it, right? You never know. But
Pain.
when the pain is telling you that, hey, this is an area that needs to be fixed, okay? But also, like, when we help you with that pain, we help you facilitate movement, correct movement, okay?
If the psoas group has been cut, then,
Psoas group? The
The
psoas
psoas
a
group.
muscle?
right, the whole group.
Oh, we don't even touch the psoas. I know exactly what you're talking about. No, we don't go again. Don't.
But if
The
before
psoas
they
muscle-
come to you, the psoas has been cut,
That is going to be. I'm sorry. Who cut their psoas?
I don't know,
Did somebody cut their psoas?
I don't know.
Okay. Look, she's talking about a muscle that's in the core. Okay, it allows you to do this. Okay, that's the psoas muscle. And if you're eating filet mignon, it's the psoas muscle of the cow, actually. Yeah. So it's a big meaty muscle. It's part of our core. I've never seen it cut before, but that's probably a surgery thing. Honestly, you can't. Yeah. I feel bad for whoever has their psoas muscle.
So we hear.
Yeah. We'll talk about that. Okay. Cool. So basically, I just want to show you guys our patients. You know. So Perry here, he came to me. He was crying. He had a lot of back pain. He got screwed over by some surgeon or something. We did a spinal cord stimulator because he had back surgery and it didn't fix his pain at all. In fact, it made it worse. So we put the spinal cord stimulator because it wasn't a structure problem anymore. It was a nerve problem. So we put it in his back. It treated his back pain and his leg pain. He's good. Now, we also did, he had pain on the sides, at the hips. We did the artery embolization. Okay, we did it for the knee. We can do it out here. Pain gone for 3 or 4 years at a time. He's good now. He's good now. This is Keegan. We did another spinal cord stimulator, same story. And then there's Ashley here. We burned the nerves in the lower back, and then she went off. I even wrote it in here. She went off to Vietnam, Thailand, and Cambodia literally a week after. And she was like, the plane ride usually kills me, but it didn't anymore. And she went and just backpacked all these. Okay, so it was pretty cool. You know. So other patients. This is my partner, Birch. He's from New Orleans too. He cares about patients. This is why I joined his practice. You know. And we did SI fusion. You know, we did the PNS for the knee. Like, they work. You know, the pain's gone forever. It's for chronic pain. You know, we do one and done stuff. Sometimes we have to repeat some stuff, but the end goal is that we get our patients' lives back. So, and that's it. That's our team. That's me. So, my car's in the back. We're only 25 minutes away. You want to give us a chance? Like, I can help you. You know. And I keep everything safe. I do everything that's just best for y'all. You know, I don't push anything. I give you all the options. You know, all this crunched in like 10 minutes, I guess. But, you know, treat you like family.
You
So-
take all the x-rays
We will order it sometimes. So for example, if we know you're coming, we'll request x-rays from your previous provider, or if we see you and we do an assessment, we'll send you for x-rays, okay? And then we'll do an assessment from there and then figure out what procedure is best for you.
Okay.
Yeah.
Do you ever recommend MRIs then, or?
It depends on what's hurting you. So if it's pain shooting down the legs, I can tell you that, and it goes especially to the feet, it's probably a pinched nerve, and MRI is the best test for that. And if I saw you in day one, I would order that right then and there. Yeah. Now,
What
if
do you
it
do with a pinched nerve? I mean, can you unpinch it or?
actually, so we can't. I didn't put this in. I guess I should have. Okay. So, all right. We'll do this for example. All right. So you have a pinched nerve. Okay. So the algorithm we do is insurances, and I agree with them in this point, is physical therapy first, right? That doesn't work. Medicine, that doesn't work. Okay. Then that's when we come in. Okay. We do. If you have a pinched nerve that's coming out of here, it comes out, it goes down your leg. Okay. And it can be pinched by a couple things. Like that disc pushing backwards on the nerve. Arthritis, where the bone is so it become bone spurs and they're sharp. They start digging on nerves. Okay. It inflames the nerve and it goes down the leg. Okay. So what we do is we do an epidural steroid injection. I'll be upfront with you. They do work much better for disc herniation that hits on nerves. Okay. It usually lasts about 3 months each time.
That's right.
Patients are okay with that. Okay. I mean they're like, listen, if I don't have to go to surgery, I'll come back here every 3 months, and that's fine. But that every patient's different. Now, if somebody says, okay, I want something more permanent, like I don't want to deal with this anymore. Okay. We do work with some neurosurgeons, but it's not a surgery still. It's just a procedure, but we can put a little device in there that actually opens up the hole where the pinched nerve is coming out.
And that lasts.
Forever. That's a forever thing. Yeah. So it's called a PSI. I can see if I can do this. PSFI.
Ejects the vertebrae? You
Yes,
just
it's
elevate?
Yeah. So here, I'll show you right now. Let's see. PSFI Aurora Zip. Just throwing out all these things. So it's a very basic concept here.
You do it, you have all this in-house?
We do, yeah. We have a team. We have a procedure center. We want to make sure that we.
You have it in-house?
Yeah. So, okay. Let's see if I can. I was trying to zoom in this thing. Maybe we can do this. Picture. Where's my clinical manager? You run away?
Oh, he did.
You were just doing so well.
I was doing so
You
well.
didn't need a net.
And then technology came on board.
I know, we-
Slow, you better get your ass out of here. Okay, here's the point. All right, this is what we're looking at. Okay, so I'll explain it in an anatomical way that people can understand. So, okay, let's look at this. So, what this is, okay, is this is your spine, and this is the back of your spine. You have the little T-Rex bones. Right? You can almost feel it on your own back, right? Now, there is a hole here, right here, and right here, okay? That's where the nerves come out that go down your leg, okay? So when somebody says sciatica, they are talking about these two nerves that come out of this hole and come out of this hole that go down the leg, okay? Now, when they get pinched, it hurts like the dickens. It shoots lightning bolts down there. It feels like it's burning. It feels like somebody's put a hot pan on your foot. Okay? And it gets worse when you stretch your leg. There's a physical exam we do. So when you stretch and touch your toes, you're stretching those two nerves that's already pinched. And it makes it worse, and it shoots pain down there. Okay? So that's your big inclination that you have sciatica or a pinched nerve. Okay? So to answer your question, okay, what can we do permanently for you? So we make a small incision, okay? This is going to be about about 2/3 of my finger, this much, okay? Like this. And about 25 minutes to 30 minutes, okay, we place one of these devices in between the dinosaur bones, okay? So what happens is you put it in the dinosaur bones in between, okay, and it stretches the bone up like this, separates them in a way, not like anything crazy, and it will thus secondarily open up the hole here, okay, permanently. So the nerve that's being pinched is decompressed now. All that pain is gone, and we know this because when we do this procedure, we have a nerve electrician expert that monitors the signal down your leg, and they can tell you before the surgery, oh, this person has sciatica, it's being lit up right now as we speak, something's pinching on it. We put this in, and then we compare it, we're like, oh, the signal's gone, nothing's pinching on it. Okay, so that is our one and all be all for
That's
this.
substantial.
Yeah,
If
it's
that
amazing.
actually works, yeah.
Yeah, no,
That's
it
part of
does
the
work.
big dogs.
It does work, but remember, it's all of these procedures only work for the right patient, okay? So don't let anyone just come in and throw these at you. Oh, what's up? How are you? You good?
I
You just
called
come back
the
from
meeting
everything?
started at 1 o'clock, so I'm like,
Oh, that's okay.
I'm
Yeah,
just hard people, I had to be here.
I know. Look, I just told her that you went to Asia and all that stuff. Oh my gosh, so there she is. Yeah. So we did the nerve burnings. I was just talking about the radio frequency
Yes,
ablation and stuff.
yes.
So yeah. There you go. I didn't plan on her coming, but here you go as a witness. All right. So to answer the question about sciatica, okay. So this right here has this is only a 25-minute procedure. Okay. It's not major surgery. They're not putting we're not putting rods in your back in cages, and then you got to wear, you're limping around everywhere. You put this in. We ask them to put a back brace for about 1 or 2 months, but you can live your life. That's fine. Like 1 or 2 months, as best you can. But like you're not on rails, you're not on crutches. The recovery is great. Like you can go ahead and do most of whatever you want. Just don't crazy twists. And we usually put it at the problem areas. Okay. So if you have degenerative disc disease, if you have spinal stenosis, if you have pinched nerves going down the leg, and you failed an epidural, I will do an epidural first before anything. I'm not going to just throw this at you, okay? Then you're the correct patient for it, okay? So, and to tell your friends, if they're like, man, I can't do anything because my legs are on fire, then maybe this little hole is a problem. And there's also another hole, but we can get into that later. But so we do a lot of advanced stuff, and we work with neurosurgeons and stuff when we do these things too. Yeah. Again, I don't.
That's like right there, man.
I know. Well, this is, to be honest with you, this is actually really advanced stuff. This has been out for several years, but in the pain world, okay? This is like a bunch of pain doctors are doing this, interventional radiologists are doing this. We just have neurosurgeons on there with us when we do something like this because we're like, hey, 2 doctors are always better than 1.
Oh,
That's what I
do you
say.
think? Paralyzed is actually a thing, it turns out.
We're very. I've never seen a patient paralyzed.
I'm just saying,
but
that's right.
That is my living.
That is right there.
If there's a paralyzed patient, I would jump off a cliff. I would never go back to medicine ever again. But yes.
Yeah, you recommend any medications?
We do. Yeah. So we start from beginning to end. I always ask patients, I'm like, at the beginning, Tylenol, ibuprofen, right? All the weenie stuff is what they say, but I think it works amazing. And then when you get to us, okay, I start prescribing a little bit stronger Tylenol or ibuprofen or meloxicam. And then I move up the ladder, muscle relaxants, okay? Sometimes it's just muscle spasm. Sometimes the arthritis causes muscle spasm. So I can treat those symptoms, methacarmol, tizanidine, rogabalin, you name it, that's fine, That doesn't work and you're having nerve pain, gabapentin, pregabalin, okay? Like it'll help you sleep, it definitely reduces nerve pain. If that doesn't work, duloxetine, which is also a nerve agent, and Cymbalta, but it can also put you in a better mood. And if that doesn't work, then we're going into the opioids, which I absolutely hate, but I will do because I'm not throwing the bat back. Tramadol, Tylenol, codeine. And if that doesn't work, then we're moving on to hydrocodone. If that doesn't work, then we're at a standard the DEA is looking at. And this is all of this is to stop you from getting from hydrocodone to oxycodone.
You personally can prescribe you.
Yeah, I can. But I will never, I don't want people to get addicted on it unless, like we try everything we can before you're placed on something like that. And honestly, I believe that most people don't have to be on unless your back is so bad and you failed everything. I mean, surgery didn't work, or you're not a candidate. None of these just don't work for some reason. Then you're like, you know what? When the DEA shows up at my doorstep, they're like, why are you prescribing? Oh, really? You know, when I write it, I imagine what I'm saying to this DEA agent. I'm like, well, that's not your bag, it's their bag. And then like, they tried all this stuff, you didn't. We escalated gradually. I never jump. Jumping is unsafe.
So organically, are you more chemically altered? Where are you on the spectrum?
Chemically, wait,
Do you like chemical alterations? You kind of can't
it depends on the patient,
or
but
organically.
I
let the
prefer
body
more
self-work.
intervention because here's the thing about opioids. They do work, that's true, but they do a lot of things people don't know about.
Right.
Okay, they mess with your hormones. They're associated with anxiety and depression. Okay, if you like testosterone, for all the guys in the room, you can kiss that goodbye. You know, all the oxycodone, all those will just lower those, and they'll increase prolactin surprisingly, and I just took my boards again, so I just know this. But prolactin is what women use, when you're lactating and stuff, and when a baby's crying and you're lactating, and it's oxytocin and it's prolactin, and it literally just like messes with all your hormones. It'll lower growth hormone, it'll lower testosterone. And those two things you need, not just because you're manly, and women have to, but the lower those are, the more pain you feel. So when you see all these longevity clinics, they're like, man, I'm hurting everywhere. And they're like, oh, you have low testosterone. You give us some pellets. All of a sudden, your pain isn't a problem anymore. You wonder why. So, if you want all that to go out the window, you can start going on opioids, fine. But at the same time, some patients need them. I'm not against it. Some patients really do. Like sometimes I get a 97-year-old who doesn't want anything except they're like, Tramadol work for me. And I'm like, okay. Tramadol is like right here in the opioid ladder. But also, it works for nerve pain and it works for every other pain. So there you go. You know?
But for every action, there's an equal and opposite.
That's true. But he just wants to play golf, so I was like, good. But some people don't. Some people are like, I hate medication. If you hate medication, then we're the right person for you. You know? If you semi-love medication, we're still the right person for you. You know? So I was interventionally trained. I was trained to, the opioid crisis really messed up everything, and then it changed the whole dynamic for pain docs. So that's why I went to UCLA because they were like, oh, we're not just pill milling. Anybody can prescribe a pill, but if you want it gone permanently or managed, and you don't have to keep coming back every 3 months, 6 months sometimes. The procedures I mentioned is usually a one and done or a once every 3 or 4 year kind of thing. And sometimes we have to do it every 6 months. Just depends.
Do you have a website?
Oh, we do. Yeah, SaveMedCare.com.
Did you get a card?
Oh yeah, I have a card in the back.